So let us start with the posterior shoulder anatomy and demonstration. Okay, fine. So in the posterior shoulder, we have the scapula, we have the humerus, and the scapular spine is there in the posterior part. So let us see what are the muscles and tendon around. Actually, in last class, we have already learned about the bony anatomy, so I am directly going to the muscular anatomy. So two big, flat, sheet-like muscles, they are taking attachment at the spine of the scapula. Remember, from above, it is the trapezius, and from below, it is the deltoid. So whenever we are scanning in the upper part of the spine of the acromion, we are actually scanning through the trapezius. So above all the structures, we have the skin, subcutaneous tissue, and the trapezius. Now, as we all know, trapezius has three types of fibers. Some fibers, they start from the top, which are in the cervical region near the occiput. They comes down and they join usually towards the anterior part, which remains into the lateral third of the clavicle. Then the fibers in the middle, they comes and they joins into this portion, that is over the acromioclavicular joint, over the acromion, and extending over the spine. And the lowermost fibers, they ascend from below to reach the seam area. Similarly, the deltoid is also having a broad attachment above, among which it starts just below the spine, continues the same area over the lateral part, which remains lateral to the attachment of the trapezius. Then it goes towards the anterolateral part, that is mostly towards the lateral portion of the clavicle. So that's about the deltoid and trapezius muscle. So these muscles will be coming superficial to all other structures. Now coming to the supraspinatus. Though supraspinatus, the main bulk is covered, especially in the anterior superior portion, we have the tendinous portion. And here, when this cover we are removing, then we are getting the supraspinatus, which are taking origin from the supraspinatus fossa. That means which is the area of the scapula over the above this spinous process. So here it is the suprascapular that is taking origin. That muscle goes below this arch and then attaches to the greater tuberosity in the anterior superior facet of it, so in the upper part of it. Next, we have the infraspinatus muscle that is taking origin from the broad infraspinous fossa, and that continues laterally again reaches to the greater tuberosity. Now we have two more muscles. One is the teres minor, the other one is the teres major. Remember one thing very importantly, teres minor is not a part of the rotator cuff. Sorry, teres minor is a part of the rotator cuff. Teres major is not a part of the rotator cuff. So you never get confused. Remember, the fourth muscle that takes part is the teres minor, not the teres major. But teres major is having an important role in the posterior shoulder ultrasound because it makes the boundary of a space that is known as the quadrangular space. Now, there are two important muscles at this point. They're not two important muscles, but two important heads of a muscle. That is the triceps. We have the long head of the triceps and we have the lateral head of the triceps. Basically, triceps has three heads. This is the long head, this is the lateral head, and another head is there which remains here. There is a groove. Can anyone remember what is the name of the groove in the posterior surface of humerus? Can anyone remember that?
Spiral groove.
Passageways groove, eh?
Yes, it is the spiral groove for the radial nerve. Just below it, we have the medial head. So we have these three heads, and among these two heads, they form two triangular areas and one quadrangular area. So this is the muscular quadrangular area. This is two small triangular areas because of this position of that muscle. Now, what is the importance? There is a nerve here, that is the main branches of the axillary nerve. They travels at this point. So if we have to block them, we can go at this point. Okay, so it is in between the teres minor and teres major and close to the neck of the humerus, where it is a circumflex humeral vessel is there. Along with we have the not a single branch, usually multiple branches of the axillary nerve can be seen at this point. So that is very important practical point. So if you have to block it, you have to block at this point. Let's come to the supraspinatus muscle. So here is the supraspinatus fossa, and we have the muscle. The topmost muscle here is the trapezius, and below the trapezius, we have the supraspinatus. And there is the supraspinatus tendon that continues towards the lateral side, going towards the greater tuberosity. Now we have to examine the supraspinatus both in the longitudinal view or the long axis view and in the short axis view, so that we can see these muscle fibers, the tendons clearly. So pathology of supraspinatus, as Dr. Roy has discussed yesterday, because the most of the pathologies are towards the lateral part, and that becomes to the anterolateral part or superolateral part. Now, we are coming to the evaluation for the infraspinatus tendon. So, to see infraspinatus better, how can we put the arm? We should put the arm adducted, because what is the advantage of putting arm adducted is that the infraspinatus will be stretched towards the lateral side. So we'll be able to see more part of the infraspinatus muscle. Okay, so supraspinatus, just remember what we have done, either the cross position or modified cross position. Here we'll be doing the internal rotation. So the position is different because in modified cross position, more of this tendon comes out of the supraspinatus. But here, if you want to see more of the tendon more clearly, then we have to make to the internal rotation position. So under the USG transducer, we have to check for the muscle belly. It is usually triangular in shape, and transducer is moved from in the long axis from medial to lateral and onto the till the greater tuberosity. Okay, and pathologies might be there. So what are the common pathologies? First of all, there might be tendinitis, there might be small intramuscular tears, there could be possibility of a large tear, even complete tear. There could be possibility of a calcification. That all I will show you. So these are the pathologies that might affect this tendon, infraspinatus tendon. Okay. Now coming to the teres minor muscle. I can tell you how to find out the teres minor muscle. Remember, in long axis, differentiating this muscle and this muscle is sometimes very difficult. So if you want to differentiate the teres minor muscle from the infraspinatus muscle, don't go for the long axis. Start scanning in the short axis. In the short axis, we'll found that there are two muscles distinctly seen here at this point. And if we scan from the medial to lateral side, we can actually see these two muscles separately. And remember, we'll be checking the teres major muscle as well. Because why we'll be checking? Remember, to first of all to differentiate from the teres minor, and also for it's our guide for the quadrangular space. Okay. Coming to the infraspinatus tendon examination. So here is the infraspinatus tendon. Infraspinatus tendon and muscle is having a pinnate pattern. The muscle is usually hypoechoic, and there is linear hyperechoic septa in between can be seen. Okay. Let's go. Now coming to the tuberosities. So when we look at the lateral side, there are facets over the greater tuberosity. So usually there are three facets. First is the superior facet. As I already told, the muscle attaches here is the supraspinatus muscle. Then we have the middle facet. Here is the middle facet. The muscle attaches here is the infraspinatus. And in the inferior facet, the muscle attaches is the teres minor. So we can examine these three facets and we can see the tendons here, supraspinatus, infraspinatus, and teres minor. Now coming to the joints. Where to find the joints? To find the joints, simply search in two areas. If you want to go for the glenohumeral joint from the posterior side, you just look deep to the infraspinatus tendon. So below the infraspinatus tendon and infraspinatus muscle, we will be able to see the humeral head, and it is distinctly and clearly visible because of its shape. Then we have the labrum, which remains just towards the medial side from this humeral head. So in case if you have to go for the posterior approach of the joint injection, I have few videos I have shared it to Dr. Joy, so he will be showing as well. So here if you want to go to this area, then you come from the lateral side and go mid-lateral to the labrum and medial to the humeral head. So this is the area if you want to go for the hydrodilatation from the posterior side, which was basically the older technique of hydrodilatation before the rotagraph interval technique was invented. And this is also very effective technique. I am not telling. Rotagraph interval is mainly given for the thickened coracohumeral ligament so that easily it can be stretched. But the posterior approach was being performed from long duration. And this is also a standard technique for performing this procedure. So at the top, you can see the deltoid, and then you can see the infraspinatus, and this is the infraspinatus tendon. But in the bony region, there is another atypicality that we have found, that is the supraglenoid notch. So today I'll be coming to that part as well. So this picture and this slide is very, very important. So try to imagine this slide, because unless and until all the pictures and slides are in your head, it is impossible to determine the pathologies. So first you have to understand which structure is which one, then you can go for the further pathologies of the procedure. So what we can expect in the posterior disease, we can expect fluid if there is effusion. There could be possibility of a tear at the posterior labrum. Here you can see the clear posterior labrum, or there could be possibility of the paralabral cyst. If they are present, we will be able to evaluate it. The importance of supraglenoid notch, I am coming just after a few slides. Now, this is the slide where you can see the pathway of this nerve, that is the suprascapular nerve. So suprascapular nerve first comes at the supraspinatus fossa. Let us start with the anatomy, because in anatomy I will be able to move and I will be able to show you how the nerve is coming more clearly. So let's first go into the anatomy portion. Can you see the 3D anatomy here? Here? Okay.
Yes.
Okay. So let us go towards the posterior side. So see, here we have the cutaneous branches. Let us hide the cutaneous branches of the nerves. Now we have the important muscles. Here I am hiding the deltoid to expose the lower portion. Now, as you see, this is the infraspinatus. Now I am hiding the infraspinatus to get access to these nerves. So let us hide the supraspinatus as well. Now I am rotating at the top. So see from where this nerve is coming. Okay. So this is the suprascapular nerve. This is coming from the C5. Then it is actually continuing further. And this is the suprascapular notch, where classically I'm just hiding these branches of the supraclavicular nerve so that you can see easily. So see, through this suprascapular notch, this nerve enters at the suprascapular fossa. So while we block through the supraspinatus, we are blocking at this point. Now, what is the advantage and disadvantage of blocking at this point? First of all, it is very reliable in location. So this nerve at this point is very easy to locate. But if we block here, it is blocking both this nerve, these branches. Remember, these are the muscular branches. This is the muscular branch which is given for the supraspinatus muscle. Similarly, from here, another branch is coming. This is the branch which is supplying to the infraspinatus muscle. So it's a mixed nerve. It is having the sensor is supplied and the genicular branch to the shoulder joint. See, this is going, and it is supplying towards the supraspinatus muscle and infraspinatus muscle as well. So if we have to block at this point, we can do it with the help of the steroid local anesthetic, or we can do it with the pulse radio frequency. But we cannot use the conventional radio frequency here because the problem will happen. These muscles will be weak because of the denervation of this muscle. So nowadays, the techniques are shifted from this region blocking at this point. Rather, they prefer blocking at this point. So what is the advantage? Remember, sensory part is the joint. We want to block the pain which is originating because of the movement of this joint. Now, if we block at this point, so this is which part? This is basically the spinoglenoid notch. Okay. So if we are blocking at the spinoglenoid notch, so it is sparing the upper two branches. It is only blocking this sensory branches. So the big advantage is that here we can use the cooled radio frequency, sorry, we can use the cryoablation and we can use the conventional ablation as well. So all three procedures can be done at this point at the suprascapular, spinoglenoid notch, not the suprascapular notch. Next comes is the teres minor. So let us hide the teres minor. As I told you, this is the quadrangular space. So you can see it is formed by one side is the teres minor itself, which I have already deleted. Then we have the teres major below, and here we have the long head of the triceps, which is attaching to the infraglenoid tubercle. Can someone remember which muscle is attaching to the supraglenoid tubercle? Which muscle and which head?
Biceps, long head.
Long head of biceps. Perfect. So it is attaching to the supraglenoid tubercle. This is attaching to the infraglenoid tubercle. Now, if you go slightly towards the lateral side, we can see the branches of the axillary nerve at this point. So I think with this 3D anatomy demonstration, everything is clear to you. Okay. Let me back to the slides. So here it is accompanied by the suprascapular artery, which could be a good guide and which is a good guide while we are performing this procedure under the ultrasound. So let's talk about the nerves. So how it looks. So when we are looking at the supraglenoid notch, then we can get a vessel and the nerve at this point by which we can actually able to locate this area. So here I have what I have told at the suprascapular notch, and here we can see at the level of the infraglenoid notch or the spinoglenoid notch. Okay. So above the spine, when we are blocking at this point, and usually there is a ligament at this point. Okay, that is the transverse scapular ligament. So here you can see the transverse scapular ligament, and below here at this point, you can see it is actually at the supraglenoid notch. Here we can see this is the at the level of the spinoglenoid notch. Okay, so we have to block at the lower part and here so that the motor vessels can be spared. So coming to the quadrangular space. So in the quadrangular space, when we look at, so we'll be able to see the triceps, teres minor, and above it will be the deltoid, and we'll be able to see the vessels and the axillary nerve at this point that I'll be showing and demonstrating in the model. So that was the anatomical part. I'll be moving towards the demonstration, but before that, Chinmada, can you continue with the previous one? Because in that case, what will happen? I'll
Okay.
make the volunteer ready.
Yeah. Okay. So last day, it was a very long class, so I could not talk about the pathology part. Anterior and lateral, just a few things about the pathology. Okay. I think everyone can see the slide, isn't it?
Yes.
Okay. So first thing, impingement and rotator cuff disease. Now, impingement and rotator cuff disease, you know all the rotator cuff muscles, supraspinatus, infraspinatus, teres minor, and subscapularis. Okay. So impingement also, there are three types of impingement. Here you see, these muscles are rotator cuff muscles. So impingement here, if
गलत है ना वहाँ ये गेट तो बोलो ना
somebody is talking, please mute yourself, Dr. Ravinder Thakur. Okay, I muted. Anyway, so you see, so there are three different places where the impingement syndrome can occur. So one is your just in the subacromial area, where the supraspinatus tendon and this supraspinatus tendon doesn't move smoothly under the acromion bone. So this is one area. Second area, when the this lesser trochanter, this lesser tuberosity doesn't move under the coracoid. When we are doing an internal rotation of hand, internal rotation, then it rotates like this. This head rotates like this. Okay, head rotates. Then what will happen? This lesser tuberosity, this should move very smoothly under the coracoid. But if it doesn't move, then also it causes one impingement syndrome. So one impingement here and second impingement here, and third impingement where the supraspinatus and infraspinatus fibers meet. So here, if you do an abduction, then these greater tuberosity, this gets impinged under the glenoidal labrum. Okay, so this is the third area of impingement. So of course, this first area is much more common than if you compare all the three impingements. So here it is written three types of impingement. So here, just a minute. Okay, so here it is written three types of impingement: anterior superior, supraspinatus tendon is subacromial space. So here between it is the between the humeral head and the cover of the coracoacromial arch. So these two things actually. This area, this subacromial space is the area where supraspinatus tendon gets impinged. Okay, and another thing is anteromedial, as I told you, subcoracoid impingement. So superior portion of the subscapularis tendon and the long head of biceps tendon between the tip of the coracoid, there is an impingement. And posterior superior impingement means rotator cuff at the junction of the supraspinatus and infraspinatus tendon. So between the greater tuberosity and the posterior superior aspect of the glenoid rim, mainly glenoidal labrum. Okay. So three stages of supraspinous tendinitis. Remember, many times patient comes to us with impingement syndrome, and many times you diagnose with supraspinous tendinitis also, tendinosis or tendinitis. Both are different, but if you diagnose a case to be supraspinous tendinosis, that need not be a case of impingement syndrome. There are differences. Okay, so first step is most of the time it is the without any tendon changes. Stage 1, subacromial bursitis and absent or minimal tendon changes. Then gradually stage 2 comes, where there is a tendinosis, supraspinous tendon is affected. And in stage 3, then it is a partial or full thickness tear. So remember, tendon when there is a problem in the tendon, disease in the tendon, so that is maybe the second stage or third stage. First stage is acute bursitis. Okay, and tendon may be normal. And another thing, as I told you, that impingement syndrome does not necessarily mean that there is a tendon problem. There can be bony abnormality like acromial head. There are different types of acromial head. So with bony abnormality, increasing osteophyte under the acromion, that space, subacromial space can become smaller and impingement can occur. Tendon may remain normal. So supraspinous tendinosis and impingement are two different diagnoses. And even the tests are also different. Okay. So here, this is the picture of subacromial and subdeltoid bursitis. So you can understand what is here. So this side is head, humeral head. Okay. Here it small part of humeral neck, and then comes greater tuberosity. Okay, so this side is lateral side, this side is more or less medial side. Okay, where is the supraspinous tendon? This is the supraspinous tendon. What is this? This part is the deltoid. This part is the deltoid. So this area, this swelling is nothing but the bursitis. Okay. Bursitis means there is a fluid. So there is a swelling. There is some deposition is there. Okay. So this is a long axis view. This is a long axis view, and this is a short axis view of the same area. This total thing is the supraspinatus. Okay. Supraspinatus tendinosis. So you understood this one? I told tendinitis. Just subacromial bursitis. Here there is no tendon problem. This is the bursa problem. So just bursa issue I have showed you. Now comes tendon problem. So this is the tendinosis. So tendinosis, what will happen? The hyperechoic. Just a minute. Okay. The hyperechoic nature, this part is normal. Okay, this part is normal, but this part is abnormal. So this hyperechoic area will become hypoechoic. And then here it is not seen that it is, we cannot say that it is swollen, but this part can become a bit swollen also. If you compare with the contralateral side, then also you will find that there is swelling is present. And with tendinosis, of course, in some patient, you may find subacromial bursitis is also there. So this is again short axis, and this is long axis. Okay. Now comes supraspinatus tear. So here, supraspinatus tear and tendinosis are two different things. So tendinosis means there is degeneration of the tendon. Okay, whereas tear means there is disruption of the fibers. Now tear can be three types. One is your articular side, and if the tear is above just at the side of the bursa, then we will call bursal side tear. And if it is in between, in the middle part, then we will say it is intrasubstance tear. Okay. So here you can understand what type of tear it is. It is the articular side tear. Okay. And not only this tear we can see some bony disruption, bony cortical disruption also we can see. So this is the tear area. This is the tear area and associated bony cortical disruption. So this thing is common when articular side tear is there. You will see a bony cortical disruption also will be there. Supraspinatus tear, mid substance. Here only one picture, short axis view. So here you can see this is a mid substance tear. Okay, so this is a short axis view. Total, this part is the supraspinatus and this is deltoid. Above is deltoid. So here you can see that this is a mid substance tear. Now another tear, This is called Barcel side tear. So here also I can see this is long axis. This is long axis of supraspinatus and this is short axis. Okay. So here you can see that when, so these are all incomplete tears. There is no, these are not complete tear, okay, or full thickness tear. So these are all partial tears. Partial tear, these three partial tears are there. So in partial tear, these are subgroups. So these are Barcel side tears. So what will happen if there is a Barcel side tear? So just between the deltoid and supraspinatus, this is the subacromial subdeltoid bursa area. So some fluid will come and like herniation, it will herniate in the area where muscle fiber is broken. Okay, so you will find this type of picture in the supraspinatus tear if it is a Barcel side tear. Now comes full thickness tear, but there is complete versus incomplete. Now, what is a full thickness tear and what is complete and incomplete? Remember, full thickness tear means if while doing a scanning long axis or short axis, okay, and a full area when you are scanning from one side to another side, you are seeing the whole length and breadth of the muscle. Then you can see at some point there is a tear which is from Barcel side to articular side. There is a connection. Okay. Then you will say that it is a full thickness tear. But think in this way that at some point there is a hole. Somebody, maybe I'm saying that, think in that way that there is a drilling. Somebody has drilled. So from this side drilling has started and this side drilling has ended. So the resultant tear will be a full thickness tear, but it will be incomplete tear, because ultimately if you go a bit laterally or medially or a bit sideways, then you will see that fiber is continuous. So those in this type of tear, we will say full thickness tear, but incomplete full thickness tear. Like here in this picture, there is a connection. There is a connection here, from here to here. There is a connection. Okay. So this is full thickness tear, but incomplete, because other fibers, if you go laterally or this side, other fibers are actually continuing. But this is a complete full thickness tear. How we can understand? So this type of picture is very common when you see that from Barcel side, the fluids are coming and it is like coming and joining the articular side directly, and a lot of fluid will be there because there is no fiber continuing. So one side is like shrinked. If there is a small tendon also, this will be shrinked like this, and this side also muscle fiber has gone, tendon fiber has gone a bit, it has retracted. So the whole area there will be lot of effusion and some loose areolar tissues. Okay, so that is called full thickness but complete tear. Progression and massive tear. So this is just for knowing that how it progresses. Last day when I was showing you the rotator cuff interval, then I told you that biceps tendon is if you put your probe in a short axis manner in the front of the shoulder, short axis manner, then the medial side is the subscapularis tendon and the lateral side is the supraspinatus tendon. Okay, so if someone is seeing the biceps tendon in a long axis way and just goes medially, he is over the subscapularis tendon in a short axis. And if he goes laterally, then he is over the supraspinatus tendon in a long axis view. So this is just a concept. You have to understand what I am saying. So just beside the biceps tendon, in the supraspinatus, so medial part of or anterior part of supraspinatus. So this is the most important area where you should search for the supraspinatus partial tear. And remember, just by the side of the biceps tendon in the supraspinatus, you have to search for the supraspinatus tear commonly. This is most common. Then it can increase like this. and then gradually from supraspinatus to infraspinatus also can get affected, and then the ultimately subscapularis also can get affected. So then it becomes a massive tear if the whole width becomes more than 3 centimeters. Now that is different issue. So now let's see what other things can happen. Rotator cuff is the main area where all the pathology occurs in shoulder. So in supraspinatus, calcification. Here you see this is a calcification picture. Okay. So how will you know that there is a calcification? Just below the calcification, most of the time, of course, not every time. It is the early calcification when you will see the acoustic shadow. Okay, this is calcification in the supraspinatus tendon. I think everyone can understand this is a long axis view, and this is the bird beak type of appearance of supraspinatus. Calcification in the SASD bursa. So it is a bit difficult to understand, but this is also the long axis view. This is also the long axis view, and this is also the supraspinatus area only. Only thing is that here, this is the bird beak appearance, SSP, supraspinatus bird beak appearance. This is the deltoid muscle, and this whole area is nothing but the SASD area, subacromial, subdeltoid bursa, this whole area, and you can see lot of calcification here. These are all calcification. Okay, so so this is like that. Okay, next is. So types of calcification, as I told you, every time you do not expect that it will have the equal acoustic shadow. So this is one type of calcification. This is also another type of calcification. These are calcification. Here you can see there is, hardly any shadow. So there are different types of calcification. I'm not going in detail of this. Okay, supraspinatus and tendinosis versus tear. Oh, this is subscapularis. Subscapularis tendinosis and tear. So as we had seen the supraspinatus tear, the same thing can happen in the subscapularis also. So anyone can say that what is this picture, which axis, and what we are seeing? Long axis or short axis? What we are seeing? What is this structure? What is this structure? Anyone can answer?
What is this?
Yeah. I am asking you that what is this structure? When we know that we are going to see the subscapularis, so what is this structure?
Lesser tuberosity.
Lesser tuberosity.
Which one?
Lesser tuberosity.
Lesser tuberosity, sir.
This one, this area. Coracoid. So orientation is must. Orientation is
Long
must.
axis coracoid.
Yes, long axis of subscapularis muscle. This is coracoid. This is the lesser tuberosity. This is the lesser tuberosity. Here must be the biceps. Here must be the biceps tendon. Okay. Here must be the biceps tendon. And this side will be the greater tuberosity that we don't need now. But then this muscle is the subscap. This is the subscap. Okay. So this part is the subscapularis tendon. And this is the your lesser tuberosity. This is the coracoid. This is the coracoid. Okay. So anyway, I will show you again. The videos are there. So here, actually, this subscapularis tendinosis, in this area, it is the tendinosis. So for seeing tendinosis, remember, always in subscapularis, there is quite a lot of anisotropy. When you see this part white, this part will be black. But maybe in this picture, the person who has taken the picture, he has tried to make it again the normal condition. He by heel toe maneuver, maybe he tried to get the fibrillar structure hyperechoic, but he did not get. Then you have to say that there is a tendinosis. Okay, so this is one thing, and here you can see the second part. There is a tear. We can see that this is a tear. So this is subscapularis, same type of same picture only. So here the tear is seen. So this is subscapularis, tendinosis, and tear. So tear can occur at anywhere. So here also, as I told you, so this is a this is also subscapularis partial tear. So these areas not very, this one is very clean. So this one is a subscapularis tear. Okay, this area is not that much clean, but this side is, you can see that tear is there, subscapularis. So subscapular tear, if there is a complete tear, so here you can see this is biceps tendon. So if this is biceps tendon and this is a short axis view, then it has to be the subscapularis area. Yeah, this is lesser tuberosity, this side has to be the greater tuberosity, and this should be the subscapularis area. Okay, and here maybe there is coracoid process like that. So in this area you can see a lot of so this picture, this effusion and loose areolar tissues, all these fats are moving. So this picture is very common in suprascapular, supraspinatus complete tear, and even in other tendon complete tear also. So if you find this picture in the subacromial area, then they are most likely it is a supraspinatus tear. And if you find this picture under the coracoid, then it is most likely subscapularis tear. So same thing, subscapularis calcification. These are calcification. You can see these are calcification. You can understand this picture. This is the biceps. This is the short axis. Okay, coracoid. This side is coracoid. And this is the subscapularis. This is the subscapularis. Okay, here also biceps tendon is there. So this is just calcification. You can see big calcifications are there. So these are calcifications. These patients are very good for barbotage and taking out the calcification, and they get very good relief. So AC joint subluxation. So in this type of picture, you will see that not only this static picture is not very diagnostic, but when you will tell the patient to move they will put his hand over the opposite shoulder and you will see the dynamic test like this. Then you will see that there is this upper surface of the acromion and upper surface of the clavicle. This difference, this distance, it changes. Sometimes it becomes small, sometimes it becomes big. So this changing in dynamic examination says that there is a AC joint subluxation. Of course, when we are seeing AC joint, we will always see the arthritis changes also are there or not. You can see. So here you can see the ending, how the bony endings are there in acromion and clavicle. So it is very nice, regular periosteal lining. But here you can see that how, if the arthritis is there, then how it will be. So in arthritis, what you will see? You will see the osteophytes. You will see the osteophytes. You will see the swelling of the joint area. I mean, the joint capsule will be taking a bit more space. It will be this area will be, you can see that effusion is there inside the joint. Okay, and so osteophytes effusion will be there. So AC joint intervention, you can see that just that you can go outside, out of the plane also, and you can go in plane also for AC joint intervention. Intramuscular cysts are also sometimes seen. Of course, we will not treat those patients, but sometimes it is possible to find intramuscular cysts while you are seeing the supraspinatus or infraspinatus muscle and tendon. Okay. So here you can see that. So this side, this is the intramuscular, inside the muscle belly, this cyst is there. Okay. Biceps tendinosis. So I think everyone can see where is the biceps tendon. So this one is the lesser tuberosity, greater tuberosity, and this is the biceps tendon. So you can see that biceps tendon has become a different hypoechoic structure. It has become a hypoechoic structure, and it is swollen, so much swollen. It is swollen and hypoechoic. So this is the picture of biceps tendinosis. Biceps tendinosis, we can see the biceps tendon in long axis also. So you can see this picture. So this picture, long axis. Okay. So this picture, we can see that this is not normal. This is normal, this side, but this is not normal. Okay. So this is again short axis normal, and this is the short axis abnormal. So these are biceps tendinosis. Now, biceps tendinosis, most of the time we see that tendinitis also is present when there is a biceps tendinitis case. I mean, like patient is saying the pain in the front of the shoulder, and you just press the long head of biceps and there will be pain. So in those cases, tendinitis is more common than tendinosis. What is tendinitis? It is the inflammatory condition. And what different thing you will find than tendinosis? So more effusion. First thing is more effusion. Here, a lot of effusion, more effusion. Second thing is synovial hypertrophy. This is a long axis view of biceps tendon. Okay, so this is a long axis view of biceps tendon. This is humerus. You can see humerus periosteal lining. So above that, you can see that there are synovial hypertrophy and effusion. Okay, so whenever you see any effusion around the biceps, you must think it can come from the glenohumeral joint also, or it can be an isolated finding. If it is an isolated finding, then only it is a case of biceps tendinitis. And when you put Doppler, you will see neovascularization, lot of Doppler signals. Okay. So bicipital tendinitis, chronic changes can be there like that. So the synovial hypertrophy is much more clearly seen here. So like that, you can see. So sometimes we can see that biceps tendon is not there in the groove and there is a rupture. But of course, these patients will not come to us, should not come to us, sometimes can come. Biceps tendon chronic tear. So biceps tendon is not there. It has been filled with some scar tissues and all. Okay. So here one more thing, biceps tendon subluxation. You can see this is, this is lesser tuberosity, this is groove, and this side must be the greater tuberosity. Okay, biceps tendon should have been here, but where it is here. So if most of the time when subluxation occurs, then biceps tendon goes over the lesser tuberosity. This is the area for common area for subluxation. And why this subluxation occurs? Remember, I told you that day that biceps tendon is held in the groove by different ligaments. Coracohumeral ligament is one of them. So if there is even the subscapularis tendon, some fibers of the subscapularis tendon, they come from this side to this side. Okay, medial side to join on the bone. So if these tendons fibers they get disrupted, then biceps tendon subluxation may occur. Okay, pectoralis major tendinitis. So this is also possible. Okay, so here you can see in MRI picture is better. The ultrasound picture is not good very much. So here you can see this is the pectoralis major tendinitis. Here we can just understand that this is the tendon. When it comes and joins here, humerus is like this. And this is the insertion on the humerus. This is the short axis view. I think everyone can understand. This is the short axis view. Okay, it's the same view. This view only. Okay, it's the same view. So in this view, you can see that this is the tendon, and here calcification is seen. Okay, no, not calcification. Tendinitis is seen. Okay. Chondrocalcinosis. So chondrocalcinosis, you know what type of gout? CPPD gout, So there it can we can see in X-ray also. Sometimes in X-ray also you see another line over the head of the humerus. This is the head of the humerus. There is another line. Okay, so this is also one crystal deposition there. So you can see by ultrasound also this type of crystal deposition. So this is called chondrocalcinosis. Ultrasound features of adhesive capsulitis. We all know that there are multiple. These are not fixed. Nobody has proved that these findings are every time present in a case of frozen shoulder or adhesive capsulitis. But many times it has been seen that, like coracohumeral ligament, this is one ligament where thickness says that increased thickness is present in most of the cases of adhesive capsulitis. So last day I showed you that short axis view. So short axis view of coracoid. This is also in the front of the chest. If you put the short axis view, if you want to see. So in this area, so this is the coracohumeral ligament. This is the coracohumeral ligament. This thickness, if it increases, then we will say that this is the this is a corroborative evidence, indirect evidence of your adhesive capsulitis. Okay, in this side, if you go directly, then you will find what you will find. You will find the lesser tuberosity and this your biceps tendon, greater tuberosity, like this. Okay. Coracohumeral ligament is directly where we see over the rotator cuff interval. Calcification, coracoacromial ligament also can have a calcification. Last day I showed you coracoacromial ligament. So this ligament also can have a calcification. But these are not very common. So let us see some videos here. Supraspinous tendinosis diagnosis. So can you understand which structure is what? Supraspinatus tendinosis. So okay, somebody tell me what is this structure, this bony structure? Supraspinatus tendinosis, what is this bony structure?
Greater tuberosity.
Which one?
Greater tuberosity. Greater tuberosity.
No.
Tuberosity.
What?
Lesser tuberosity, sir.
Pictures, just a minute.
Please say before which is the medial side and lateral side actually. Then it will be comparatively clear to them.
But this bird beak appearance is not clear to them. Okay, I'm just trying to see. This is the bird beak appearance. Okay, this is the bird beak appearance of supraspinatus. So if this is bird beak appearance, then this side has to be the greater tuberosity. Greater tuberosity, this side means this side is lateral side. And this side, you know from where the tendon comes. Acromion, under the acromion. Okay. Now try to think long axis. This is long axis view of supraspinatus tendon. This bird beak. Try to think. Understood? So we are putting the probe like this. Okay. I think now can you understand? Can you understand the picture? This is
Yes,
the
sir.
bird beak appearance. Okay. So wherever
Yes.
the bird beak appearance goes, that is greater tuberosity. Okay. This is the neck.
Okay.
This is the acromion. Okay. And I am showing you here in this picture, supraspinous tendinosis means I am showing you here this area, which is not at all hyperechoic or white. This is black. This is black. So that's why I'm just telling you that this is a supraspinatus tendinosis. Okay. Anyway, so next slide, I go. supraspinatus tear complete. Earlier I showed you tendinosis. Now I will show you the tear. So here also patient is sitting. This side is medial side. Okay. Medial side, this side. Lateral side, this side. Now you see I'm going over the acromion. Going over the acromion. I'm going over the acromion. And you can see only one muscle. That is the deltoid. That is the deltoid. And below that, so this is the deltoid muscle. These are skin and superficial tissue. And after that deltoid. And here fluid, lot of fluid. Okay. Lot of fluid. So in this type of picture, when you see, then you know that this is a complete tear. And which muscle is there? So this area is for supraspinatus. Here another picture. This is a short axis. So understand this short axis here. So in this short axis, what will happen? Medially, it will be subscapularis. We can see the subscapularis tendon in this side, but we cannot see the supraspinatus. Supraspinatus tendon will be lateral. Understand this part very conceptually. Understand that. So just a minute. Okay. So try to understand the thing conceptually. Okay. Anyway, yeah. So try to understand. So that in this patient, what is happening? So, there is no option. This is the long head of biceps, and from this side it is the subscapularis, and from this side it is the supraspinatus. Okay, so if you put a probe like this, then what will happen? You will see the just in the middle you will see the biceps, but lateral side, this lateral side, you will see the part of supraspinatus, and in the medial side you will see the subscapularis. So that is what we are seeing. The medial side we are seeing the subscapularis, and lateral side there is no supraspinatus. Okay.
Understood.
Try to understand this picture. Otherwise, orientation takes time, of course, but still. So lot of fluid, and this picture, this fluid area should be there in your mind. It is there everywhere. Wherever there is a complete tear, this picture is there. There is a lot of fluid and some fat, is loose areolar tissue is floating there. Okay. Okay. Now I am giving a SASD Barsa injection. Wait. So I think all of you can understand which picture is this. Again, bird beak appearance of the supraspinatus. So I am making it from long axis to short axis. Can you find where is the subacromial bursa effusion? Can you see that? Now it is a short axis of supraspinatus. Let us see from here. Okay, this is a long axis of supraspinatus, bird beak appearance. This is the greater tuberosity, neck and head. This is the acromion, and this area is the bursa. So this area is the bursa, and here you can see some fluid, some black color fluid is there. So this area is the bursa. So this now it is the short axis, and this type of fluid is not normal. A lot of fluid is there here. This is the bursa fluid. This is the bursa fluid. You can see in short axis. Okay, between deltoid and supraspinatus, there is a lot of fluid. So this is called SASD bursa effusion. See, clearly you can see there is a bursa effusion. There is a bursa.
Yes. Okay, fine.
Okay, so this is the Barca effusion. Okay, I will not show you the full not needed. So okay, one more thing was there. So not only the Barca, when I was just going again in the short axis, see here it is the anterior part of the supraspinatus, just in this area. So anterior part of the supraspinatus, I am seeing in a short axis. You can see a clear tear, supraspinatus tear here. Okay, this is a clear tear, supraspinatus tear. So in these patients, supraspinatus tear and SASD bursa, both are the diagnosis. Can see clearly, just this is the area where we should always see. Okay, just you can see this is the round biceps tendon, and just at that side of the biceps tendon, that is the anterior part of the supraspinatus. So there is the tear we can see. This is the tear, clear tear you can see. Okay. Okay, we will go in the subacromial SASD bursa intervention. So where I will go? I will go here in this black line, Okay. So you see my between white, this black line is there. It is the bursal plane. As soon as I will give the injection here, it will split two muscles completely. It will not stay there. It will split two muscles. So my needle tip is here. Okay, this is my needle tip. So now I'm I'll make it a bit fast. Okay. So I've given some amount of here, and these are drugs actually. These are all depot drugs. So I've given the whole amount, and this is the classical in the bursal plane. Both the muscles are separated. Subcoracoid bursitis. This is so. If we go a bit down, then subcoracoid bursa we can see it is fluid filled. Okay, I'm just telling you. So, this is the short axis view on the biceps tendon, long head of biceps, short axis view. So you can see. So which side is medial and which side is lateral? So this side is medial, left side, and this side is lateral. Okay, so you can see the biceps tendon, and just medial to the biceps tendon, this is the lesser tuberosity. Here a bony shadow comes and goes. This bony shadow is nothing but the coracoid process. Here you can see bony shadow comes and goes. This is coracobrachialis. So anyway, where is the polish? Yes, it comes and goes. So this is the coracoid process, and below coracoid process you can see some amount of fluid. So this is nothing but subcoracoid bursa. You cannot say that there is a rupture because of why? Because you can see the subscapularis muscle here. So this is the subscapularis tendon. I mean, subscapularis tendon here. You can see, and this fluid is above subscapularis tendon. Can you see clearly? If someone cannot see, please tell me. So, okay. So this is the fluid area. So you can see this is the subscap. This is the subscap, and this is the lesser tuberosity. So in a short axis manner, so fluid is here. So this is the subscapular bursa effusion, subcoracoid bursa effusion, not subscapular. Okay. So injection, we are doing a procedure in the subcoracoid bursa. Any bursa, you can go inside, aspirate and give steroid, no problem. Bursitis is an acute condition, and if you give steroid, patient will become better. So we are taking out, aspirating. So this has become much smaller. And actually, we wanted to see that whether it is a vessel or not. So he gave some, this one, Doppler. He used Doppler, but it is not a vessel. So, yeah. So like that, we aspirate it and don't give a steroid. The supraspinatus tendon. So this is bursitis. Okay, diagnosis. Okay, so supraspinatus tear diagnosis. Supraspinatus tendon. Okay, so here you just see the same thing. Here it is a articular side tear. Okay, articular side incomplete tear. You can see some cortical disruption and the associated tendon, hypoechoic tendon. So this is the supraspinatal tear, articular side in this area. Okay, I think you have understood this part. Intervention. So this tendinosis, we are doing some intervention. So you can understand the picture. This is a long axis view over the supraspinatus. Our needle is coming from lateral side, and it is just at the tendon where the we can see the small tear. Okay, so at that area, we are doing injecting the PRP actually. Supraspinatus tendon PRP injection. Okay. Okay. Bicipital tendinitis diagnosis. Of course, this is only a short axis view. Long axis view is not there, but you can see a typical picture. This actually doesn't tell you tendinitis. This tells the peribicipital tendon effusion. So you can see the picture, very nice picture. Okay, so the tendon, hyperechoic tendon in between, and around that, this is the hypoechoic effusion. So if there is no effusion in the joint, then we will say that it is a bicipital tendinitis. And if there is associated TA, then we will say that this is the extension of the effusion of the joint. Rotator cuff interval intervention injection. So we are injecting inside the joint. Okay. We are injecting inside the joint. We are coming from lateral side and we are going towards the medial side. So I have just punctured the coracohumeral ligament. Okay, under the coracohumeral ligament, and around the side of the tendon, the whole area is rotator cuff interval. Wherever you inject, I am injecting actually 40 ml of 5% dextrose. So 40 ml, but still there is no fluid. Fluid is just going very easily. So you know that your fluid is going somewhere else. Otherwise, how can it be that you are giving fluid and it is not there? So this is the rotator cuff interval access to the glenohumeral joint. Okay, so you see where I have kept just beside I punctured the coracohumeral ligament. It is coming from the coracoid side, this side, coracohumeral ligament punctured below I came. So you can actually, your needle can be here also. Wait. Okay. Something's there. Okay. Well, now I think we can write. So your needle can be here also. Your needle can be here also. I put my needle here also. So anywhere below the ligament, it is the coraco rotator cuff interval. Acromioclavicular joint injection. This is being done by Dr. Devjyoti. I'm making it a bit fast. So here, needle is.
And remember, it is out of plane technique. It is not in plane.
Okay.
Because in acromioclavicular.
Now you can see the tip. Yeah. You can see the tip, and acromioclavicular joint basically out of the plane is always, we also do most of the time out of the plane, because that is the most easiest. You just locate the joint at very superficial and you do the out of the plane technique. So I think this much only. Yeah, already it is done. So this much only here. Yeah, needle is there, so he will give some. We'll do the intervention here. Okay. Biceps tendon sheet injection. So this is a case of bicipital tendinitis. Here, there is no associated joint diffusion. Yes. So it is just around the biceps tendon sheet. Okay. Yes. This is also glenohumeral joint injection through rotator cuff interval. So needle is coming from the lateral side. Here, it is a bit difficult to see. So this side is lesser tuberosity. Okay, this side is greater tuberosity, and this is the bicipital groove. This is the bicipital groove, and this is the tendon. This is the tendon. Okay, this is the tendon, and this side will be, of course, lesser tuberosity. So this is the biceps tendon. You can see this is the tendon, and the needle has come just. Yeah, so just beside the tendon. So you have to puncture the coracohumeral ligament anyway, and then come under it. So you are just beside the tendon. So yeah, to maybe injection, I mean fluid is being injected. That's why there is small amount of swelling, but most of the fluid is gone. Yeah. Okay. So this tendon is also hypoechoic, but that is during intervention you cannot keep the here. Suprascapular nerve intervention. So one can see that which structure is what. First, let us see which structure here. So this is this part is scapula. Here is the transverse scapular ligament. Yeah, transverse scapular ligament, but this is the suprascapular fossa. This is the suprascapular fossa. Okay, this part, total part is supraspinatus. This part is deltoid. Okay, so here it is the long axis view. long axis view over the scapular spine. So,
Small correction, it is not delta, trapezius.
trapezius, yes. Trapezius, annotate, no, not annotate. Where is that? Stop. God. Share. Okay. So this one, okay. This was a long, out of the plane or in plane technique. So this is done by Dr. Devjyoti. So this is in plane technique. Okay, the needle we can see it is coming, and since the degree of angulation is too much, so you cannot see the whole needle completely, but you can see where is the tip. So tip has come. Tip has come in the right area. Now, after giving small amount of fluid, we will see that the fluid should spread under the transverse scapular ligament here. So you can see the tip. Tip is in the correct place. Yes, so fluid is, being injected, drug is being injected, and you can see it is going up. Muscle plane is going up, and fluid is there. Okay. Okay. Any other injection? No. Thanks. So I have showed the all procedures of anterior and lateral part of shoulder. Now Dr. Devjyoti will demonstrate the posterior shoulder first. Then I have two videos, of course.
Sir,
Yeah, tell me.
Hello?
sir,
Hello? Yes.
sir, mid-substance tear versus tendinosis. The picture, does it look the same, or how to
No.
differentiate?
Tear is tear, tendinosis is tendinosis. Tear is always there is some fiber is not there. Okay. And tendinosis is all fiber is there. Only the quality of fiber is not up to the mark. So tendinosis, you will see most of the time it is at the near the footprint where the tendon is going over on the bone. At the footprint area only you will see the tendinosis. But mid-substance tear can be a bit proximal because there is a critical zone concept. 1 centimeter proximal to the insertion where the insertion is that Bartwick appearance insertion, 1 centimeter proximal to that is the critical zone. Most of the tear is found there. Even in the tendinosis area also you can find. Picture is different. Picture is not same.
Hello? Hello?
Yeah. Audible.
Am I audible?
Yes.
Okay. So let me start. So I think you can see the volunteer. So we are standing at the back and ultrasound machine is in front. So that is the usual way by which we can actually see the shoulder posterior part. So first I am showing you starting from the infraspinatus. Supraspinatus is already demonstrated by Dr. Roy, but if you want, I can repeat also. Do you want a repetition of the supraspinatus, or I will directly go to the infraspinatus?
Yes, little bit imaging maybe.
Excuse me.
Repeat it, please.
Repeat it. Okay, fine.
Very
So,
Please repeat the
okay,
supraspinatus.
fine. I'm just covering the supraspinatus fossa as well. So here is the spine. So anything above the spine, here is the trapezius. And just below, here is the fossa. So to see the fossa, the fibers are coming like this. And here it is going under the acromion arch. My volunteer is a little bit lean and thin, so it will be very much clear. I am keeping the index marker towards the medial side so that the portion on the screen on the left will be the medial side. So here lies the fossa. So I think you can see these big supraspinatus fossa. Now, if we go down, you will see I'll be just moving over to a bone and everything will be lost. See, we cannot see anything at this point. Okay, I think we need to change the direction of the camera because you are not able to see anything here from this area. Okay, so as we are seeing at this area, we can see this is the fossa. Now from medial to lateral, we can see this hyperechoic bony margin that has been shown where the my cursor is here at this point. This is the hyperechoic bony margin. So this is the scapula. Now in the middle, we can see the supraspinatus and the trapezius. So muscle at the top, here this muscle, I think you can see my cursor. This muscle is the trapezius, muscle below is the supraspinatus. As I move further lateral, we will be able to see this whole of the supraspinatus muscle is going under this bone. So this bone is basically the acromion. Now at this point, if we move slightly up, remember as I shown in the picture, the suprascapular nerve is seen in a just slightly at the top. So to find the suprascapular nerve, we have to first hold the probe like this, and then we have to move slightly up to get the notch. Okay, so here we are getting this bony break. So my model is very lean and thin, so you can see the artery moving that can be seen. Okay, just
Deluji, you use the arrow.
yes, I think I have to use the arrow, then it will be easy. See at this portion, try to see the movement of an artery. Just 1 second. I'm in a very odd place to show. Now like this. Okay, I'm closer to the see. Just I am taking the marker, scribble, pointer. Okay, so I'm taking the pointer and see here at this point. Okay, can you see the artery moving? At this point, I'm taking it out so that you are able to see. Okay, so this is the area where we get at this point, we get the suprascapular nerve. The patient is very lean and thin. That's why you are seeing this so superficially. Otherwise, in most of the cases, it is comparatively deeper. Okay. Okay, fine. Again, we can see it is here at this point. Okay. Here we are having the transverse, this one is the transverse scapular ligament and below it is, okay. So because of this model being lean and thin, you can see so superficially both the structures. Here is the transverse scapular ligament and here is the artery. So basically this is the suprascapular nerve. Now we can start following the infraspinatus. So let's go slightly down to see the infraspinatus. I am reducing the depth. Okay. So here from medial to lateral, what we see is the infraspinatus muscle. And at the top, we can see this tendon. Okay, this tendon is clearly visible. Let me do one thing. We start the virtual convex so that we can see this is not a true convex, but it's a virtual convex so that I can delineate more area. So here you can see this is the central tendon of the infraspinatus muscle. So above we have the deltoid, below we have the infraspinatus, and it is the central tendon of the infraspinatus. And see, as I'm going laterally, this tendon is over the glenohumeral joint. Below this rounded portion is the glenohumeral joint. And if we go farther laterally, it is getting attached. See, further going lateral, now here is the greater tuberosity. Okay, so it is going and attaching to this greater tuberosity. I think you can see a large area and widespread area. Now you can see clearly two things. Okay, actually this much beautiful view is not easily found in most of the cases. So let me stop and let me show. So in this portion, you can see this area is the head of the humerus. Now, what is this triangular structure? Triangular glistening structure? Can anyone tell?
Labrum.
Yes, this is the glenoidal labrum. Next, we have the bony portion starting from this point, and this is the above going is the infraspinatus tendon. So let us clear and go medially. So it's a big area, cleanly seen, and sometimes if the patient is very fatty, getting this type of beautiful picture is not always possible. So you learn what is ideal and then go for what is practical and what is possible. Now at this point, we can see the labrum still and we can see the notch. So where is the notch? See, this portion is the notch portion. So just by the side we have the labrum. Here this portion is the labrum. This is the glenohumeral joint. This is the central tendon, and below at this portion we have the notch. Along with we have see the nerve and vessel at this point. Okay. So in most of the cases, it do not take the color. Accidentally, if it takes, then it is fine. Sometimes it may, but most of the time it usually do not. Let us increase again. No. No, they are all noise. No. So at this point, just removing the virtual convex, decreasing the depth to show this picture more clearly, to focus more into that area. Okay, so here is the moving vessel. I'm just kept by ring over this moving vessel right now. Okay, so here you can see I am stabilizing my hand more so that you can see the picture of the vessel, and probably this one is the nerve. Okay, sometimes it is very difficult to locate each and individual nerve, but at least you can see this area, and you have to put the needle at this area if you want to block the suprascapular nerve at the spinoglenoid notch. So this is the bony part of the acetabulum. This is labrum, and if you want to enter here at this point, that means posterior part of the shoulder joint, the posterior portion of the entry, then your needle should come like this and should enter at this point. Okay, so that is the posterior entry to the joint. So this portion is clear, I think. See, here at this portion we have the
Devji,
yes.
you can freeze and mark the areas, I think. Otherwise,
Yes, that I can do. Let us freeze. Actually, I have done once, so I do not want to repeat again and again. But anyway, let us do. Here, just see, this is the bony acetabulum. Bony acetabulum portion. This is the labrum portion. This is the head portion. This is the notch portion. SGN. And here is the nerve and the vessel. Okay, at this portion we'll be finding the nerve and the vessel. This portion is the deltoid, this portion is the infraspinatus, and this is the central tendon of infraspinatus. All right, all structures clear?
So what is the bony acetabulum?
This is the bony part of the acetabulum. This is the
glenoid, glenoid.
Bony glenoid.
Sorry, I am really sorry. Actually, sometimes the supex and inflex gets confused. So it is not the acetabulum, it is the glenoid. Okay, I am really sorry for that. Okay, so this is the glenoid cavity and it is the glenoidal labrum, not acetabulum. It is my mistake, sorry. So these are the structures that you have to remember. Okay, let's move. Here we have another important thing. That is, we have heard about two types of impingement previously, but here we have third type of the impingement. Okay, so what is type of impingement? This is known as the posterior glenoid impingement, or it is also known as the, just one second, the same way I should hold. Now, if I ask the volunteer to externally rotate the hand, fold the hand and externally rotate, বাইরের দিকে নিয়ে যাও, you see, এরকম হবে না, এটাকে এই জায়গাটাই থাকবে, just one second. So I'm holding it here. Okay, so that we can see the head. Let's be on virtual convex, so more area, it will be easier. Okay, so we can see virtually more area. Now we are rotating it so that you can see the head is rotating. Now in our site we have the greater tuberosity. Now further we are moving lateral and see this greater tuberosity is going closer to the labrum. Now what happens in few cases, in few cases, while this portion is moving like this, the labrum gets impinged within this area. Okay, so see, under the greater tuberosity, there is an impingement between the labrum and the greater tuberosity. So basically, it causes a lesion, sometimes tear, sometimes degeneration in the muscles which are attaching over the greater tuberosity, namely the supraspinatus, infraspinatus, and the teres minor. So that is a pathology, and that sometimes is possible. So in those cases, you do a dynamic examination like this. See, I am doing a dynamic examination. I am just moving it lateral, and while going to this portion, the patient will be having pain, and the labrum will be tucked under this greater tuberosity. Okay, so this is another type of impingement in the shoulder, though the subdeltoid and subacromial impingement is the most common type of impingement. So now we have seen the infraspinatus. Now another thing is also important. While examining infraspinatus, you put the hand in the internal rotation so that we can see beautifully the infraspinatus. Now let us move towards the cross section. So we are rotating the probe. We are rotating the probe 90 degrees. Once rotated, we'll be able to see the infraspinatus fossa. So above we have the spine. This portion is the spine. Let us start drawing as well. So this portion is the spine, and here is the whole infraspinatus fossa. Now, if we go down from this fossa, okay, so till now we can see the infraspinatus only. We can see beautifully the infraspinatus. We are going medially, we are going laterally, we are seeing the infraspinatus. Now, as we go down, we see another muscle. See, I am holding that muscle in the center. So can anyone name what is this muscle? This muscle, this muscle, teres. Which teres? This is teres minor. Okay, so here we are having the infraspinatus, here we are having the teres minor. Then what is this muscle below? This is a large muscle. Below the teres minor, we can see a large muscle. So what is this muscle?
Teres major.
Yes, fine. So we have the teres minor, infraspinatus, and teres major. And one thing remember, finding out this muscle only on the long axis view is a little bit difficult, because you will not get the margin where the infraspinatus is ending and teres minor is starting. So at the teres major, teres minor junction, if we go laterally, What are we expecting? Can anyone say what we are expecting? So, anyone? Some muscle will come from below. If we go medial to lateral, it is the long head of
Tricep.
triceps. Yes. So, as we are going laterally, we will see just follow the teres minor, and I'm holding in an opposite way. I think that's why it is not coming properly. Okay, fine. So, just 1 second. How further? Okay.
Your left side is
I am just trying to orient the things. Otherwise, it will be difficult. So right now, I am just, that's why it is a occurring problem, because now it is the correct orientation. So here we can see the first, it is the infraspinatus, then it is the teres minor, then we have the teres major. Clear? So left side is superior, right side is inferior. Okay. In the meanwhile, I'm changing that we get the lost the orientation. That's why the problem occurred. Now, as we are going laterally, so see, teres minor, just follow the teres major and minor. So below, right, still now we have the teres major and minor. As we are going laterally, you see, just below the teres minor, we can see another muscle. See this muscle. So in between the teres minor and teres major, another muscle starts getting inside, coming. So this is the long head of triceps. Clear?
Clear.
Okay. So this muscle is coming in between the, so it will go superficial to the teres major and inferior to the teres minor. So we can see this muscle. This is the long head of the triceps. So now large portion we are seeing is the long head of the triceps. And slightly above, this is the teres minor and this is the teres major. In between, we have this large long head of triceps. As we go further lateral, okay, so the long head of triceps will be gone. See now, the long head is gone and we are starting with the lateral head of the triceps at this point. And in between the long head and lateral head, you see there are some vessels coming. Clear at this point? Vessels and nerves, they are coming. Okay, so can you see the vessels and nerves at this point where my red circle or pointer is there? Can you see? This is the circumflex iliac vessel. See, I am just putting the vessel under this pointer. Okay, just above my round pointer, we have the circumflex humeral vessels and the axillary nerve. See, I am just, so can you see honeycombed nerve at this point? So usually they are not a single nerve, they are branches, and this is the axillary nerve. Should I freeze? Yes. So this area is clear to everybody? Or should I repeat?
Isn't it?
So once, repeat, sir, once.
Okay. How I got this area, I'm just repeating. First, I try to find out this infraspinatus, then below it is the teres minor, and then it is the large teres major. So this is the teres major, this is the teres minor, and this is the infraspinatus. Okay, this one is the infraspinatus. Then we have the teres minor, teres major. Now from the teres minor, teres major junction, I am from medial side. I was in the medial side, I am going laterally. So once I started going laterally, I see this long head of triceps. See, in between the minor and major comes the long head of triceps. As we go further lateral, the long head of triceps is ending, and at this point, we are started seeing some vessels here, and this will continue. Okay, this will continue over the neck of the humerus as well. If we go further, it will come over a bone as well. তুমি হাতটাকে সোজা করে ধরো, আপনার এদিকে না। আগে যেমন ছিল করা। So if you have any problem, you go back to the previous what I am doing. So at this point, there is teres minor major going lateral. Then these are the fibers of the triceps. These are the fibers of the triceps. Now, as we go further lateral, just below this teres minor, we start seeing these vessels. Okay, so these are the vessels. Clear? And the axillary nerve. Clear at this point? Can you see these vessels?
Clear, sir.
Okay, fine. Vessels and nerves. So these are the axillary nerve and the circumflex humeral vessels. Now, the last part, but not least, is the getting the picture of the facets. So, to see the facets, so as the hand is slightly internally rotated and I have to go much lateral, but if the hand is not here, the same thing can be visible slightly from the posterior side. So at this point, we can see 3 facets distinctly. Okay, so these are the facets over the greater tuberosity. So here it is the superior facet, and above this is the supraspinatus. This is the middle facet, and over it is the infraspinatus. Remember, supraspinatus takes a larger area over the facet. Then this is the inferior facet, this line, and here we have the teres minor joining. So these are the muscles in the facets of the greater tuberosity. Okay, so these are in the demonstration part. So any questions in this part or any area you want to me to redemonstrate?
You did not demonstrate the supraspinatus area.
Supraspinatus area I have demonstrated. I have suprascapular nerve I have shown.
No. Bird beak appearance they wanted to see, no?
They wanted. Do you want to see the bird beak again? Could not understand. Okay, fine. Let me show you the bird beak as well. I have not understood that. I thought supraspinatus fossa. So once again, I am showing you the bird beak as well. So to show the bird beak, again I am holding in the same pattern. That means my index marker is towards the medial side. I am just putting my probes. This is the acromion. I am just holding it over the acromion. Okay. So here we can see the acromion at this point, and just below the acromion is our supraspinatus. Now, getting a better view is what we always want to show. Just 1 second. Okay. See, actually that bird beak was distorted because of the virtual convex. Now you can see large portion. See, left side it is the bony contour you can see. So that is almost till the middle of the screen. That is our acromion. Now from that acromion, we have a bird beak appearance that is going up to the, see, this is the bird beak. Can everyone see that bird beak?
Yes.
Yes.
Okay,
Yes.
so it is going up to the greater tuberosity. So why we do this modified transposition? Because in normal position, most of the part will be hidden under the acromion. Okay, but as we are doing this modified transposition, then large part of this tendon we will be able to see. See, Now a bigger part of the tendon still we can see that is coming under the acromion and that is getting attached at this point. Okay, so this is the classic Bartbeck appearance of the supraspinatus. Okay, I thought it was the fossa only. Anyway, here is the fossa. The vessel is visible. So let's go for the pathology portion. Now, actually, maximum pathology has been discussed. Only a few pathology, which is actually for the this infraspinatus, they are only not discussed. So let me go to
Deputy, will you show some videos or I will show? Hello?
hello, just 1 second. Chinmada, I do not have the videos. I have shared it to you. I have not kept in my slide. So you saw the videos. Hello.
Yeah, just a minute. I'm coming.
Am I audible?
Yes, you are audible.
Okay. So I'm just showing the pathology slides. There are only few in the posterior area. Then you show the procedures. Okay. I'm not included in it. So let's start with the posterior shoulder pathology. So one thing that I've already told you, that is the posterior superior glenoid impingement. That is the impingement of the rotator cuff, especially at the junction of the supraspinatus and the infraspinatus tendons. And that occurs during the maximal abduction that I have just shown and in the external rotation of the arm. Now what happens? Pinching occurs between the greater tuberosity and the posterior superior aspect of the glenoid rim. And this leads to degenerative changes, results in the partial tear of the posterior part of the supraspinatus tendon, typically on its undersurface. Now coming to the infraspinatus tear. Now this is an intrasubstance tear of infraspinatus that is being demonstrated here. And you can see this is the articular portion and this is the portion which is close to the deltoid. Now, here we can see the calcification within the infraspinatus. So this look will be similar as we have seen in the supraspinatus. So it will show an acoustic shadow of this calcified image. Moves to the next. This is the complete full thickness tear of the infraspinatus. So here the only muscle you can see here at this large portion is the deltoid. The infraspinatus is already torn and in a small portion you can see it, but most of the portion is taken by the deltoid. Now this is the joint diffusion. So as I told, this is the normal glenoid. We can see the humeral head at the glenoid and we can see this is the fluid portion. And here in the joint diffusion, the fluid comes to that area. Okay, so you require a little more fluid to come here. If the fluid is very mild, it might not be able to see this, but this is possible when the effusion is more. Now coming to the paralabral cyst. So it's a large cyst. I've given the source as also, it's from the radiopodia. So this cyst is a paralabral cyst which is taking a large part of it. Okay, so it is under the supraspinatus as well as it is extending under the infraspinatus as well. So labrum is a large area. So if there is a large cyst, that can take this picture as well. So that was few pathologies in the posterior part. And Chinmada, you can start with the interventions. Are you there? Hello.
Yeah, hello, Dajati.
Yes, yes. You complete the intervention part, posterior. Interventions is there with you?
Yeah, just
Okay.
showing you the interventions. Okay. So, intervention, yeah. So this is one infraspinatus tear, insertion point. So you can see, so this is the infraspinatus insertion area. So this is a infraspinatus small tear. And as I told you that anywhere there is a tear, you will see some, if it is a articular side tear, then you will see some articular disruption also associated with the tendon. So here you can see, this is the glenoid labrum. This is the glenoid bone, labrum. This is the infraspinatus tendon going in the greater tuberosity. Okay. So again, you see, so this is the area where there is a disruption of the articular bone, and this is the associated tear is also there. Okay. So this is a intervention from the posterior side, glenohumeral joint intervention. We have already shown you glenohumeral joint intervention from the anterior side, from the rotator cuff interval area. Now I am showing you the intervention from the posterior side. Here actually the needle is puncturing the glenoidal labrum. It looks like so. So it should not be. It should go below the glenoidal labrum. Okay, it should not puncture the labrum also. And it though you should more avoid touching the articular cartilage. This area is articular cartilage. So needle should not hit the articular cartilage. That is very painful also, and cartilage gets damaged. But so there is a, I mean, your needle should come between the cartilage and the glenoidal labrum. So here the injection is giving in the going in the right place. There is no doubt about it. But maybe the needle has come through some part of the articular cartilage. So you can see this fluid. Yeah. Anyone is asking anything? So this is also another glenohumeral joint intervention. But this is, so here you can see anything rounded when you are seeing below the scapular spine, below the scapular spine, then as soon as you see a rounded structure, you know that is the humeral head. That is the most easy way of locating. Humeral head means rounded structure, rounded margin. So this is humeral head. There has to be the glenoidal labrum, and here has to be the bony glenoid. So this is the bony glenoid. This is the triangular labrum. This is the needle is coming from lateral side between the articular cartilage of the head and the glenoid labrum. Okay, needle you will not see in a better way because the angle is a bit steep. Okay, but you have to understand the orientation. It is a long head, long axis probe positioning over the infraspinatus tendon. You can see this is the labrum, glenoid bone, humeral head, and this is the needle coming from the lateral side just between this articular cartilage and labrum. Okay. Can you understand the orientation? Is there any confusion? Anyone has any confusion, please tell me. Because these orientations are very much necessary. You see the recording multiple times, open the images, anatomy images, then only you will understand which structure should be found where. Okay, so this is done. Labral intervention, this is actually, I mean, this is not my video, I got it from somewhere. So here, I will not say that this is a very, I mean, for diagnosis purpose, you must not do with ultrasound. Diagnosis should be with MRI. And I mean, posteriorly, as we were going inside through the labrum in the joint, you can remain inside the labrum also. Here you can see some labral tear can be seen. Okay, so if that really matches the area through which you can go, then you can do the procedure, PRP injection in the labrum. But otherwise, this is not a very nice way to see a large part of labrum. Only a small part can be seen. If really you can see a tear there and you can match with the MRI, then you can do some intervention there. Okay.
So I
Devjit?
think we have finished.
Yeah. Yeah, we are finished
So
now.
any questions? Otherwise we'll end. Yes, today we have continued a little long. Okay, bye-bye for today.
Yeah, somebody, Dr. Muhammad Ajli has some question. Dr. Muhammad Ajli, do you have any question? In the chat, there is something. Okay, anyway.
Nothing.
So,
I have question.
Sir,
yeah,
sir,
tell me, please.
sir, even infraspinatus is having bird beak appearance, no, sir?
Yes. All tendon, most of the tendon have bird beak appearance. Yeah.
Okay, sir.
Most of the tendon. Yeah, only in some cases where actually tendon is so small, then you do not see a bird beak appearance. Okay. Like say your short head of biceps. It is going in the head of the coracoid process, then you do not see a bird beak appearance. But otherwise, most of the tendons have a bird beak appearance. Okay.